Pressure growth managed by exploratory laparotomy with divisional endoscopy on 3rd March 2023. Patient was managed with divisional endoscopy is functional and patient is already allowed. Due to in view of prolonged mechanical ventilation, patient was tracheostomized on 23rd March. Currently, patient is off ventilator. We're trying to decannulate the tracheostomy tube. The patient currently has an uncuffed patient.
So here not the face.
Patient was started ambulating today after being put off mechanical ventilation. We're starting with also has a midline burst abdomen for which daily dressing is being done. The wound is granulating. Patient has become malnourished due to prolonged bed stay. We're starting with arm physiotherapy and arms and leg physiotherapy and started trying to build the patient nutritionally so that we can manage him better.
Clinic flexure growth, no?
Yes.
So what are the options? What were the options to begin with?
So, what we can do for splenic flexure growth, we can do extended right hemicolectomy. And for the
Clinic flexure,
yes, sir.
right or left?
So, it is if because the splenic flexure blood supply is scarce, so we can do extended right hemicolectomy. We can do splenic flexure growth resection with the margin, or we can do left hemicolectomy. But
We can do all of them or one of them is an option.
sir, better if we can approach with the right extended hemicolectomy or splenic flexure growth resection, because that will be a better option than doing left hemicolectomy.
So treatment depends upon the performance of the patient. Since this patient has a
Performance status.
performance status of this patient, since Apache was more than around 20, sir. So we have made
No, at that time, that is all right. Patient came in obstruction
yes.
and they did a diversion because in emergency, you would not do a definitive surgery. That is it, that is all right. And patient was having an Apache 2 score of more than 20, which meant that the patient was not even fit for a haircut. So you would not do a very radical surgery in that situation because the treatment should not be worse than the disease. No? So you would like to do we did a diversion. Namaste, namaste, namaste. So diversion is what we can do. That is what was done. And now we can plan a definitive resection and so on. Of course. So that part is over. Now we are in the patient is recovering, and as he rightly said, he is in a state of cachexia. Why is cachexia very common with the colonic growth?
Because of the cachexian release, sir.
Which we are discussing why is cachexia common? Colonic growth.
GI malignancy, cachexian is released more in the GI malignancy. In the large body tumor, so it leads into anorexia.
Because there is a large space for the tumor to expand, and we can have limited blood supply is reducing as we are expanding. There is more of necrosis in the center, more of tumor necrosis factors are liberated, more cachexin, and that leads to cachexia. So it's very common with colonic growth, vesical growth, pancreatic cancer. They are known to have cachexia, which leads to a catabolic state. Correct?
Yes.
So he is talking about, which is a very good point he made, that we are trying to correct his cachexia so that we are ready to take him up.
We're building the patient up, sir.
What did I ask you? How do you? Why is cachexia more is answered? You understood? Have you understood what I spoke? I think they are looking long. Come आगे आ जाओ. They are happy and recovered, that they don't want to answer anything. So we will correct what? How do you correct it now?
Sir, we calculate the calorie requirement of the patient according to the weight, and we focus. So we at least 100 grams of glucose has to be given for the brain and the RBCs to function. Then we focus more on the protein because we don't want respiratory muscles to become to go into catabolism, because we need good respiratory effort from them. So we give him 1 to 1.5 grams per kilogram of protein, and the rest is covered by fats and carbohydrates. We also give micronutrients.
Partly correct. Anything to add?
we can give TPN also. Then if patient is not taking orally properly.
So micronutrients we need to compensate most of them, because since the patient is for a long stretch, patient has not been taking orally properly, so we need to compensate for the nutritional loss that would have occurred.
They are also known to get the dehydration very frequently. Take care of that. He's got a stoma in place, and then we can plan a surgery. You know what else would be once the patient's performance status improves, then we can plan some definitive treatment at some point of time. Now the tracheostomy now needs to be decannulated.
So we progressively, in adults we use a cuff tube. So in this patient, for example, a 7.5 size cuffed tracheostomy tube has been inserted percutaneously on 23rd March. So now since yesterday the patient has been weaned off of mechanical ventilation. The patient was on pressure controlled ventilation. From that he was shifted to pressure support ventilation. After that, serially, patient was maintaining saturation and PO2 was good on ABG. So the patient was weaned off of mechanical ventilation. Put the patient on TPs, after which the oxygen requirement was gradually decreased. Now the patient is maintaining saturation room air. After that, we have to give a trial of whether the patient the normal airway of the patient is functioning and there is no softening of the trachea. So that for that we deflate the cuff and then check the saturation and the vitals of the patient. And sir, we can, if the patient is maintaining saturation, then we can insert a smaller size tracheostomy tube serially. We are planning to change the size of the tracheostomy tube today from 7.5 to a 7. For that, we're planning for that today.
That was very nicely answered. So do you decannulate a tracheostomy tube? Why did we do a tracheostomy in this case? We were managing with endotracheal, we were managing with a tube. So why did we do a tracheostomy, Aishman?
Because we prolonged, if we intubate the patient prolonged, there is chances of other infection, and there is increase in the dead space, and if we want the patient to be intubated for more than 7 days or 14 days, we have to do tracheostomy for the better care. So we can give patient orally also if once patient is off the ventilator, and then it is better than tubes.
Okay, any difference of opinion or anything you want to add? Prolonged endotracheal intubation has its own complications and problems. So Gokul, what are those?
There can be some respiratory tract infections and
You know what? Any tube in the body is lined by something which produces mucus to keep it moist, and it has got a lining of cilia which keep on pushing the foreign body out. So when you put the tube inside the tube, this action stops and the mucus would collect or get stagnated. Cilia won't function. So when cilia don't function, the muck collects, and whatever is stagnant will get infected and inflamed. That will lead to inflammation, which will lead to stricture later on. That is why the recommendation is always put a one size smaller tube. Don't make it snugly fitting. One. And if you have a nasogastric tube in place, which is in the esophagus, and a tracheostomy tube in the trachea, there are two tubes, and between these two tubes, there are two walls. That's how tracheoesophageal fistula is a complication of when there are two tubes, because they will produce that pressure effect. Clear? So when you are thinking or you are anticipating prolonged intubation, one, you keep changing the size of the tube. It's applicable to catheter in the urinary catheter. It's applicable to the nasogastric tube. It's applicable to tracheostomy tube. It's applicable to endotracheal tube. Keep reducing the size over a period of time. This is called decannulation. As you make it small. Now, why do we need tracheostomy? Because tracheostomy kills off the dead space. And dead space is not that you measure from nose to this distance is 5 centimeters. It's more than that. It's a, sinuses, parapharyngeal spaces. There is a lot of loss that will happen. So with the tube inside, you are managing it, but then there is a problem with it. The tracheostomy is an advantage. You have an easy access to the trachea, you can clear off the bronchus, the secretions. So it is easier, but there is a risk because this space was provided to take care of all the infection, foreign bodies, everything. You can't start breathing from here. So then the infection and direct introduction of infection becomes a problem. And that is why stoma, the tracheostomy care becomes so important. So everything has a flip side. But once you are done with the tracheostomy function, gradually make the tube smaller, which is what he said, and then finally we'll just close it. Correct? And then we build up the patient on nutrition as you rightly said. First correct calories always. Otherwise if you give proteins to a catabolic state, in a catabolic state if you give proteins, they'll get utilized as carbohydrates, calories. So that's like burning gold, and you don't want that to happen. So first the calories. Correct the calories, then you get on to the proteins. You know, if somebody tells you to take your meals only as eggs, one egg is how many calories? 60 kilocalories. So that won't give you enough calories. The protein will get utilized as calories now. It won't build up your muscles. Proteins are important not only for the muscles and body makeup, enzymes, because enzymes are nothing but proteins. For the digestion, the appetite return, and everything will start happening automatically. We'll first correct the catabolic state, then we'll plan his surgery and we'll take him off for surgery. Even chemotherapy cannot be given to a patient with a low performance status. Any therapy cannot be given. So that would be the plan. And coming to the surgery, the three options you gave, extended right is removing a lot of large gut for no good reason. Most of us would do extended left. And extended left hemicolectomy would go beyond the splenic flexure up to the middle colic left branch. If I may show you, so you will go beyond. So, ileocolic, right colic, middle divides into two, and then there is a left colic which comes from the inferior mesenteric artery, right?
Yes.
Sigmoidal, etc. Marginal artery of Drummond goes here. I am not getting in there. So if there is a growth here, you go here. If there is a growth here, you go here, beyond. So one pedicle, so that you are able to get good lymphatic flow. So extended left is an option. Extended right is mostly for transverse colon growth. If you move towards the transverse colon, then we can do extended right. In this case, left. You know why they don't do left is because to mobilize the colon down for anastomosis then becomes a challenge. But when you are resecting it, it's not a problem. You have to mobilize the hepatic flexure and then you can bring it down and do the anastomosis colocum. Correct? Any question?
So when the patient of splenic flexure growth comes in acute obstruction, so would it be a good idea to go for a extended right as the entire large colon proximal to the growth would be dilated?
So how does dilatation help you?
Because then we need to remove that also. Because
Why? Just because it is dilated, why would you remove it?
Because sir, if we do a left hemicolectomy for this
When the
patient,
growth is gone, obstruction is gone.
then so the
So it will not dilate.
proximal dilated colon would have to be anastomosed with a distal collapsed colon, sir. And that would have
You mean
a slight
the
discrepancy.
technical discrepancy? That is temporary. It will get resolved. Because this is dilatation because of the distal obstruction.
Yes, sir.
When you are removing the distal obstruction, this would be gradually decompressed, which you see in every time in small bowel obstruction also. No?
Yes.
So just because the small bowel is distended proximally, there is a risk of discrepancy happening. You can do some chittling and manage it. But nobody is going for immediate, in an obstruction case, you don't do immediate anastomosis. You will put the patient on therapy and then the second stage you will go for it.
In that case, sir, we can, if we are anastomosing it primarily, even in the discrepancy, we can do diversion
Then you
ileostomy.
can do a diversion ileostomy if there is a discrepancy. That is, it's a risk in your mind that it might leak. That's the only thing, no?
Yes, sir.
What can go wrong with an anastomosis? It can leak. So that will happen due to various factors, and one of them could be discrepancy, but naturally you can achieve that. But just to achieve that, you don't want to resect out the whole of the ascending colon. What is observed? What is observed in ascending colon?
Ascending colon part of vitamin K is absorbed in distal ileum and some part of the ascending colon.
Mainly electrolyte and water, sir. Only
Water and short chain fatty acids. Water and short chain fatty acids. But you don't want to lose them. And there's nothing like an extended right without taking some part of small gut also. Now, 18 centimeter of small gut, whole of ascending normal colon, transverse colon. No, I don't think that's fair.
Okay. A 35-year gentleman with a swelling in the right inguinal region, which expands upon cuffing and right inguinal. Yes.
It expands and then goes back. Cuff impulse is present.
Cuff impulse is present and the swelling is reducible, sir.
I think we'll exclude it.
Post-operative day 11. Post-operative day 11 of a case of gangrenous cecum with cecal perforation managed by exploratory laparotomy with right hemicolectomy with end ileostomy and drain.
क्या हुआ बाबा, आवाज क्यों आ रही है? तकलीफ हो रही है क्या? कहाँ पर तकलीफ हो रही है? सांस में दिक्कत हो रही है? इसको जरा सेक्शन करो. तो चल रहा है, नेबुलाइज कर रहे हो.
Case of cecal perforation managed by the right hemicolectomy with end ileostomy, sir. Currently, the patient had developed a surgical site infection and wound disease, for which we had to remove the polyps, which is the patient currently has a burst abdomen. The stoma is functional, patient is allowed. The stoma is functional, sir, and the patient is allowed orally. Apart from that, the patient has a poor respiratory reserve. He has bilateral added sounds in both of the lung fields. So, sir, patient is not able to cough properly. For that, sir, we've started nebulization with Duolin and Budocort, sir, 3 times a day, along with sir incentive spirometry and the chest physiotherapy.
Now, how did this patient present and how was this decision taken? Aisha?
Patient presented with a chief complaint of mainly with peritonitis in the emergency room.
It is a case of perforation peritonitis.
Yes, sir. With
An opening and we found fecal blowout. Now, if there is a patient with fecal blowout, what all should you look for?
We look for
Nebulization चलने दो बाबा, इसको डिस्टर्ब नहीं करो. हाँ, इसको ठीक करो. आराम से लेके ठीक हो जाएंगे अभी आप. हाँ, घबराएं नहीं.
we should look for any distal obstruction which may cause cecal blowout and
Sir, if there is a cecal blowout, we should look for any distal obstructive lesion in the colon. It will be intraluminal or any extraluminal growth can be seen.
So distal obstruction. So we need to exclude a left-sided growth producing right-sided symptoms. Now, how would it produce so? How does this blind loop syndrome happen?
yes, because ICJ is a one-way valve, sir. Anything which goes beyond the ileocecal junction, and if there is a distal obstruction, there will be a collection of all the bowel content between the obstruction and the ICJ. So there is the cecum has a scarce blood supply. So when it distends because of the bacterial infection and the content, and it will gradually the blood supply to the cecum decrease and it will necrose and blow out, sir. Because of that, sir.
Okay, make it better.
So according to Laplace's law, when the cecum is distensible and it distends because there is proximally there is IC junction and distally there is an obstruction. It forms a closed loop. Now according to Laplace's law, the cecum is distending and then it gives way because it wall thins out. That is why there is distal growth.
ischemia and gives way. So what should have been the option? If suppose this patient was not to come, I mean the Apache was how much?
So his Apache was more than 10 points.
So he was in a group 2. Okay, so what are the options you had?
So one was to remove the diseased colon and form an endoileostomy and close the distal stump, sir. Second was we could have done a tube cecostomy and then do
No,
a
but the cecum had blown out, no? So you can't do a tube cecostomy. The cecum was in pieces. Then
Limited resection can be done, sir.
limited dissection can be done, which used to be called as quadricolectomy.
Yes.
The term is no longer used. Quadricolectomy used to be right hemicolectomy, left hemicolectomy, and quarter colectomy, 1/4. So it used to be cecum and a part of ascending colon. Right. But then you don't do ilio-ascending anastomosis because it doesn't do very well. Why doesn't it do very well, Terry? He's not answering, so I don't know.
Because right colic artery is maybe sometimes absent or to blood supply.
Ascending colon is a fixed part,
So one is a ascending colon partly is retroperitoneal. So it doesn't have a serosa there. It tends to leak. Secondly, it is an anastomosis between a fixed part and a mobile part. So it tends to give way easily. This is the reason. So it's preferred to do ileo transfers rather than ileo ascending anastomosis. Now you can argue ileocecal भी तो है ना, there is an anastomosis, but then that's nature's adjustment. So the anastomosis, we used to do it very commonly in the past, but it is suggested and it is recommended that you anastomose a mobile with a mobile part. So both have mesentery, they have good blood supply, both have serosa, so they heal better. So that's quadricolectomy of the limited resection which you can do. Third option, if your patient is too sick and you are yourself not very competent to do it, then you can do an ileostomy and bail the patient out and yourself out of the situation. This is called bailing out surgery. So that you live to fight another day. Not that you would be doing everything on that day. But that's like you did a very good operation but the patient died. That's not a good idea. Okay? Now what is the next step? Can you इसको सोने के लिए बोल सकते हैं या मैं तो क्या बात?
Yeah, talking about the options in this case. Diversion, ileostomy, bailout surgery.
Bailing out surgery so that you can manage it subsequently. If you are asked a bailing out surgery, then come here, beta. That is the answer to the question. Sometimes the patient is too sick to withstand a very prolonged surgery, but you don't want a definitive surgery. The patient may not survive that surgery. So then it is much better to do what is life saving at that time. And then you can, on limb saving, life and limb saving is important. Then you can always do a planned and definitive work later. His chest is not too good, so what is being done for that?
So
Why is
chest-
the chest bad? What is there?
History of chronic smoking.
So
History
there
of
is-
chronic smoking.
Finish now.
History of chronic smoking for the past more than 30 years.
Bronchi.
So because of wound dehiscence, the splinting action of the diaphragm is also reduced. So there are poor respiratory efforts because of that. So secretions are not getting out properly. So for that, we're doing chest physiotherapy, encouraging him to do the incentive spirometry, and we have started nebulization.
Surya, if you have to auscultate for all three lobes on the right side and two lobes on the left side of the lung, which is the best place? MBBS question. Terry? You see how quickly we forget.
Posterior side.
Posterior. It's the axilla. You'll get to hear about all. No? This is taught in medicine, in Hutchinson. Don't forget things to learn new things. Remember what was taught earlier. You all knew it. You're all good students. Now also take care of the DVT prophylaxis, which is a protocol in our unit, and we will stick to that. Gradually the chest would get better. And you're right, any laparotomy, the diaphragmatic movements are restricted, which leads to basal atelectasis. So be careful about basal pneumonitis that may happen and patient will be sick for a longer time. Chest physiotherapy should be postural also. And we, of course, will get an X-ray chest done to see which side is doing worse. Right? Any question relating to definitive treatment later on? When should you close it? You got a stoma, you've done a limited resection. We actually done right hemicolectomy.
Yes, sir.
Because it was a pulled up cecum, correct?
Yes, sir.
So if it is a pulled up cecum, Sabya, what is coming to your mind?
Sir, abdominal cords can be a cause.
So tuberculosis is one of
Tuberculosis.
possibility, where the cecum gets pulled up and the ileocecal angle is obtuse, and it could still be malignancy, although it could not be made out. That's what I know. There is no left-sided growth, but patient would need colonoscopy to confirm it. We have already sent a CEA. CEA is Is a very specific marker or non-specific? Tell me some benign causes of rise in CA.
So it can be something like PID. So it can be in
PID, smoking, and CID,
smoking.
smoking. Simple condition. Anything relating to liver, cirrhosis, hepatitis, alcoholics. It's not a very specific marker, but sensitive. So you can use it for follow-up, but not for diagnosis. You name any diagnostic tumor markers? Shagun?
Yes, sir.
Rishikesh? Interesting question. You guys are very smart at MCQs, no? Diagnostic tumor markers. Most tumor markers are prognostic.
Yes, sir. In testicular malignancy.
No,
Sir,
they are
in
not
pros-
diagnostic by and large.
So prostate specific antigen more than 40 is mostly suggestive of a
Prostate
malignant.
cancer and
Um,
calcitonin for medullary carcinoma. These are two tumor markers that are diagnostic. Others are mostly prognostic. I agree with you. Alpha fetoprotein and LDH can guide you towards seminomatous or non-seminomatous growths in testes, but they are not diagnostic. I hope you understand. Raised calcitonin, medullary carcinoma thyroid. Confusion? No. PSA, high PSA. PSA can be raised in many conditions. Prostatitis, post-prostatic massage also. So, there are very many cases, causes for that. But specific if it's more than 40 years.
Sir, can amoebic typhlitis leading to sickle blood, sickle perforation, sir?
Question. It's a very good question. Can amoebic typhlitis be the cause of sickle blood? Yes or no?
Yes, sir.
How?
Rare cause, sir, because it causes ulcer in the cecum, sir. Ascending colon flask shape ulcer, which are usually
Have you seen them? This is taught in the pathology. They are flash shaped. Which side is the mouth of it? Now the answer is pathology question now, right? Amoebic ulcers are flash shaped ulcers looking at you. So the narrow part is outside towards you, the broader part is deeper, right? But almost never they perforate. They don't perforate commonly. It's except in immunosuppressed individuals. So it is possible in immunocompromised patients. It can happen. It does happen. We have seen that liver abscess, ruptured liver abscess and ruptured cecum both had the same disease. About 8 or 9, series of 8 or 9 we published, where simultaneous amoebiasis of the colon with rupture of amoebic liver abscess, so both coexist, can coexist. Clear? But not a common disease. Not a common disease. इससे पहले इस चीज़ पे जल्दी जल्दी बताया कि बोलना जाए क्या था patient is covered.
The case of carcinoma rectum. Patient presented to us with complaints of bleeding per rectum for the past 9 months. So the growth is on distal rectal examination. The growth is felt almost 4 to 5 centimeters from the anal verge, and the finger cannot be insinuated above the growth, sir. It is a hard growth, sir, and is fixed to the mucosa, sir. Apart from that, sir, patient has undergone CECT, which showed, sir, a growth 5 centimeters from the anal verge, around 8 centimeter in length in craniocaudal, and 3 centimeter almost in width, completely obliterating the lumen with no involvement of any surrounding structures or any lymph nodes.
Anything more you would like to say?
Yes, we should say about the where it is actually reaching the lower limit.
The growth moves with the Valsalva, which means that it is free from the surrounding structures. There is no Blummer shelf, and also an indirect evidence that it is not infiltrating is that there is no lower limb swelling on the left side.
What would be the first symptom of infiltration of the sacral plexus?
Sciatica, sir.
Very good. What would be the first clinical feature of anterior involvement? This is posterior. Anterior?
Sir, big UTI-like symptoms. sir.
Urinary symptoms, right?
Frequency.
Frequency.
And you can have hesitancy, frequency, hematuria, etc., etc. Right? What else? How do you differentiate that? What is the difference between left-sided growths from the right-sided growths?
Yes, sir. So right-sided growths are usually present with either lump, obstruction, anorexia, asthenia,
No, that's not correct.
But,
I'm sorry.
altered bone.
No, that's okay. Start with basics. You come to loads straight away.
Yes, sir. The patient presented with sir features of anemia. Sir, patient usually is weight loss with vague abdominal symptoms, sir, in the right side colonic malignancy, and there may be patient may present with obstruction in emergency, but that is a rare scenario, sir.
Late.
Late
So
scenario.
now you can come to what you were saying. You were right, but that's later. You know, because there's a lot of space in the cecum.
Yes.
And we remember it by the mnemonic. Same mnemonic that we have for cancer stomach. Loads. LOADS. Lump, obstruction, anemia, asthenia, anorexia. D for dyspepsia, and S silent.
Silent.
And silent is, it may manifest as liver metastasis, it may manifest as ascites, it can manifest as blummer shelf, or left supraclavicular lymph node or the Werkow's node. These are, of course, that would be very late, but what I'm trying to say is it can be even silent. Clear? Now, which of these parts of LOADS were there in this patient?
So this patient has a left side, is a case of rectosigmoid.
So, what would be the left-sided growth features?
So the patient has increasing constipation, and the stream of the stool becomes thinner, and the patient also has a bleeding per rectum, sir.
Then add. That's well answered, but there's more to it.
along with that, sir, if the growth has the patient is presented to us late, he can have symptoms of lower limb weakness and sir,
Okay.
pain.
Spurious diarrhea, sir.
Spurious diarrhea. And
Yes, sir. And
Sir, if
increasing
sphincters
use
are
of
in-
constipation.
tenesmus,
Yes.
which the patient in ward 1 has, the other patient of C rectum. She has tenesmus.
Yes, sir.
What is spurious diarrhea and what is tenesmus?
So spurious diarrhea is when the growth in the
Spurious
left
means
side.
false.
False.
Right. So the growth is, left-sided growths are constricting, right-sided are ulcerative. So they bleed. Melena is a feature of right-sided growths. Fresh bleeding is a feature of the left-sided growth. Feeling of incomplete evacuation, tenesmus, they are features of the left side growth, right? And spurious diarrhea. Spurious diarrhea is because there is narrowing, the fecal matter collects above that, bacteria act upon it, it gets liquefied, mixed with mucus, then it comes out as a stream. Patient thinks he's passing stools. So that's why it's called a false diarrhea. Spurious means false. Tenesmus, what is the reason?
So when the internal sphincter gets involved, then the patient has this urge to pass stools, for which they run towards the washroom. They have to put efforts to get the stool out, but then there is
They
none
just
come
produce
out.
what? Would you like
Mucus.
to
Just-
add that?
Only mucus
Just
comes.
produce mucus, sir.
Mucus and some blood.
Some blood,
So
sir.
it is
with mixed-
tenesmus, and it causes pain a lot of time, which gives you a false feeling that it is obstruction, which also is important to understand. Clear? And if a patient or Ayush or maybe Aman, if a patient of colonic cancer who was all right till about Thursday starts having severe loss of appetite from Monday, what do you think has happened? Are you able to comprehend the question, or I could not put it properly? You have got it?
Yes, sir.
Liver metastasis.
Liver metastasis.
One of the first features of liver metastasis are loss of appetite. So you should be careful. Although loss of appetite would happen due to the cancer also, we have discussed it. Cachexia is a factor. Okay, now this patient is a case of carcinoma rectum. How did we reach that diagnosis? Based on history, and then on examination, what did you find on DRE? Just about reaching there.
Yes.
अरे आप एक मिनट जरा आवाज ना करें भाई साहब.
Almost 4 to 5 centimeters from the anal verge, sir, a growth can be felt in the interior wall of the rectum, sir. Which is, sir, the mucosa is not free above it, and the finger cannot be insinuated above the growth, sir.
Insinuated means you can't go
You can't
beyond.
go beyond. Can't go
You
beyond.
be
Sorry.
insinuating
Can't go
anywhere.
beyond.
Any other part? You mentioned about Valsalva.
Yes.
It's a very useful thing to do. What are the implications? What are the uses of Valsalva in these patients?
So if the growth moves downwards on Valsalva,
Basically, if you can get above it or not.
yes, sir.
When you can't get above it, then that's where you use Valsalva to see if you can get above it. So it tells you the superior extent, mostly. As far as the mobility where the mucus is concerned or underlying structure is concerned, we have to move it. Okay, and if the sacral hollow is free, pre-sacral fascia, no symptoms, patient has no sciatica, no pain, no neurological symptoms in the limb, then you're fine, right? What would be the features of lymph node involvement?
Sir,
Terry, you also should answer.
lower
Somebody
limb
else.
edema. Lower limb edema.
So edema, lower limb edema will be there.
What for symptoms are not. What is edema? It can also be neurovascular. No?
Yes.
Where does it go?
Pararectal ends are
Ascends up, right?
Ascends up, yes.
And it is different below the dentate line. No? What is the difference?
So they go to the inguinal node below the dentate.
Because it is squamous cell carcinoma. And lymphatic drainage is to the. So all right, we put it there. Before and above the dentate line, what are the differences?
Yes, above the dentate line, sir, there is it is the so the epithelium is sir most of is adeno matlab
Columnar.
columnar epithelium, sir.
Below that it is
it
stratified
is
squamous.
stratified squamous.
Next,
Next,
what is
sir,
the
the
nerve
blood
supply
supply.
above?
Sir,
Autonomic.
nerve supply is autonomic, sir.
Below
Below
that,
it is
somatic.
pudendal now. Yes, sir.
Somatic.
Yes, sir, somatic nerve supply. Sir.
And third, the blood supply.
Above it is, sir, branches of celiac artery, sir, which is
Systemic.
systemic supplies. Sir,
Portal below.
mesenteric.
Above portal, below system.
Supply systemic.
Nerve supply,
Lymph nodes,
lymphatic drainage goes to the pararectal and
portal veins.
portal. No, it goes along the inferior mesenteric and all that. It goes up. And from below the dentate line, they go to the inguinal lymph. You should know. So depending upon, that's why we now don't use the term cancer of the anal canal, cancer of the rectum. We call it anorectum. And embryologically, you differentiate it based on dentate line, don't you?
Yes,
Right? Correct?
Yes, sir.
Now, what would you do to investigate to know the resectability?
Sir, resectability, we do, sir, MRI in this case, sir, because colorectal, so we can see the circumferential involvement of the surrounding structures with the involvement of the sphincter. So we can do sphincter preserving surgery or not, and we can do the lymph nodes. We can see the lymph nodes, even though CT is better than MRI for look for the lymph nodes, sir. And
So I'll sum it up for you.
yes,
So MRI will tell you the three-dimensional picture.
yes,
You look for the mesorectum.
yes.
You look for the lateral extent, circumferential margin is more important than
Then
the longitudinal margin in rectum. Distally you don't need a lot of margin, but proximally you do, and circumferentially you need it. Correct? That's why TME has come into place. Okay.
Yes.
Now TME was the concept of getting it in an envelope. You go between the endopelvic fascia and you know about TME, we discussed it in the mesorectum. So the fat belongs to the rectum, the fat should come, the mesorectum should come out. So that's where the lymphatics are. So there was a time when basically surgeons doing rectal surgery were divided into TME surgeons and non-TME surgeons. So we gone out of that finger thing, where you break it and remove it. So we do a sharp distinction. But there is also a school of thought that it may cut off on the blood supply, which may lead to the anastomotic challenge.
yes.
But it has been proven that it's no longer true as long as you are carrying the dissection in the right place. Broadly speaking, should it be easier in a male or a female to do a APR?
female.
Let him answer.
Female.
Naturally, the question
Female.
itself is the answer.
Female, sir.
Easier in a lady because the pelvis is spaced, and between the bladder and the rectum there is a vagina and the uterus, which are protective. So it will not involve the trigon of the bladder early. If that gets involved, it's not resectable.
Yes.
And in that case, the patient will go for neoadjuvant chemoradiation because sphincter preservation is a standard of care. wherever possible. How much is the distal margin you require in surgery? 2 centimeters. Actually 1 centimeter, but you need 1 centimeter for the donut
Yes, sir.
of the stapler.
Stapler.
So 2 centimeter distally, proximally you can take up to 5 to 7 centimeters. It's not a problem.
Yes.
So we'll do a CT and MRI both actually. CT is for the lymph nodes. MRI is also good for lymph nodes, but CT is slightly superior in picking up the nodes. Correct? One. Number two, you've done MRI. Some people talk about transrectal ultrasound also.
Yes.
But we know that this is non-invasive and you're able to get the same answer. The plan is TME. And which planes you go into?
Holy plane of heels, sir.
This is the holy plane of heels. That is for the mesorectal excision. Anteriorly you go between wind and water, the male. Water is bladder, wind is rectum, along the fascia of Denon biliaris. You've all been taught in anatomy.
Yes, sir.
The fascia of Denon biliaris. So you go in between the two planes. And that is both the abdominal part, lower part you take it. You'll see that during surgery tomorrow. Or you can watch some of our APR videos to get it. Right. So when you're taking a consent, take all this. Is it possible to do low anterior resection or ultra low in this patient according to you, your assessment?
Because a patient, sir, we can, it is 4 or 5 centimeter from the anal verge, sir. Still it is low, sir. If patient is not symptomatic, but we will look intraoperatively also after in the GA, sir. If 2 centimeter is,
You see, this centimeter is counted after you have mobilized it.
yes,
So it gets a little longer during surgery. This centimeter is not before surgery. Once you have mobilized it, it gets a little longer. See? The effort should be to preserve it. And today the standard of care is in locally advanced rectal cancer, always put the patient on neoadjuvant chemoradiation. Take up for surgery subsequently. What neoadjuvant chemo?
Folfox,
Folfoxy and the radiation?
for radiation, we do some brachytherapy can be done, sir. Or
What do you practice normally in our institution?
EBRT, sir. EBRT we do, sir.
Well, that's about this case. Any questions? Is he fit?
Yes, sir. Hemoglobin is 9.62 from our side, sir.
Sir, one thing is a patient, we do 2 types of APRs, sir, cylindrical and conical APRs, sir. Sir,
Conical APR is they are called coners, no?
Yes.
Coners are, now you won't be able to record from there.
For post-operative day 1 of a patient of ruptured splenic abscess managed by exploratory laparotomy with emergency splenectomy, which
So
are
that's slow. Let's speak slowly. Splenic abscess which had ruptured. Yes?
Yes,
You can tell more.
Yes, sir. The patient was
Now you can finish.
So patient has presented to us with complaints of pain abdomen for the past 2 days, sir. Patient was a follow-up case of splenic abscess which had ruptured.
It is a known case of
Yes,
splenic
known case
abscess
of
that came with
splenic
features of peritonitis.
Yes, sir.
So which meant splenic abscess has ruptured.
Yes.
Right?
Yes.
So splenic abscess, common, Rishi.
So it's mostly common in immunocompromised people.
Why is it rare in immunocompetent people?
So lymph again clears up all the
This is your main
lymph.
lymphoid organ. It's a lymph node. It looks like one also. And it is the, in fact, it protects you against all these infections, etc. When it itself has fallen sick, you can imagine the patient is obviously not too good. What are the causes of splenic abscess for the benefit of everybody, if you could rattle out? If you don't know, it's all right. If you know, it's okay. There are, first of all, remember, there are no mistakes. There are only lessons. Commit your own mistakes, correct them, and also learn from others' mistakes, because life is too short to learn only from your own mistakes, right? Causes of splenic abscess.
yes, sir. In a immunocompromised patient with, sir, systemic sepsis, any malignancy which
Okay.
involving the
If you
spleen.
don't
sir.
know, stop.
Yes, sir.
So any septic emboli coming from somewhere else, hepatitis media.
Relax. Septic emboli coming from where?
So anywhere in the body, like hepatitis media or something, some bone infections there.
Correct. What
Septic
else?
arthritis is there. So any valve
Infective endocarditis. And patients who have received treatment for venal stones in the form of ESWL. What does ESWL stand for?
so extracorporeal shockwave lymphocytosis.
In that shock wave, there are micro hemorrhages in the spleen. and they may get infected. Then subacute bacterial endocarditis, where there is an emboli, septic emboli again. So
Osteomyelitis.
then in osteomyelitis, which you mentioned, and in general in immunocompromised individual, it can come from anywhere. There could be portal pyemia leading to splenic abscess. How will it lead to splenic abscess? Let me ask somebody else. How will portal pyemia lead to splenic abscess, Ram?
So, portal vein has it was drained by a splenic vein and
Good. It's formed by inferior mesenteric vein or superior mesenteric vein.
And splenic vein.
So the superior mesenteric vein and splenic vein join to produce portal vein. So if there is portal vein pyemia, this would mean a retrograde splenic abscess. That's a possibility. What is the common cause of portal pyemia?
Appendicitis.
Very good. In an immunocompromised individual, appendicitis. What are the other causes of portal pyemia?
Diverticulitis.
Diverticulitis, others, salpingitis, pelvic abscess. Just imagine wherever the portal vein is draining. So all these portal pyemic patients may also have splenic abscess, but when you are immunocompetent doing this, like spleen is your soldier guarding the borders. When this is down, then the country is gone into complete failure. Your immunity is down. That's important. So, is that the first option? Why did we do splenectomy? We could have just drained the pus. And why didn't we manage, like last time we managed by, when this patient, the same patient came to us 6 months ago. And we managed by percutaneous aspiration and putting a pigtail. Why did it require surgery this time?
There were signs of peritonitis.
Rupture.
Rupture, signs of rupture.
No, peritonitis due to rupture. So you manage peritonitis like if you manage an abscess. But the source was spleen. And this is usually associated with lots of adhesions once it is ruptured. So later on it can get organized, but patient may be very ill. One, you may have an immunosuppressed individual. So what about the testing for immunity? What all has been done?
So viral markers were done, HIV, HCV and HBS.
They're negative?
They're negative, sir. So he's a known alcoholic, sir. So that could be one cause, sir, because the liver is not functioning. So the immune cells are not being created by the liver.
Alcoholics are mostly immunosuppressed anyway, because when they take alcohol, they also don't take certain other things.
Yes.
No, they don't take nutrition. So they're malnourished because they think alcohol can take care of almost everything. Most of the time it does, but later on there is a problem. When it overtakes the individual, right? So alcohol is not good for anyone. Alcohol means disaster. Tobacco means disaster. So there is no advantage. Don't read in between the lines. Red wine is good for heart. So little bit of alcohol is good. Little bit of it's very similar to saying little bit of poison is good. Because after some time you'll develop our immunity towards that poison. That is ridiculous. Because by that time you develop that immunity, you would be dead. So, no alcohol, no tobacco. But for a surgeon, these are both dangerous things. You'll get early tremors, your aging would be faster, your performance status would keep on dropping. It's a sad thing that we advise our patients not to take alcohol, but lots of us take alcohol. So, before you tell somebody not to take alcohol, you should take. There is a story of Mahatma Gandhi. When immediately after freedom, or before freedom, people used to come. He would have a, kind of a darbar, not darbar. People would come and ask him for various problems, and he'd give an answer. There was a long queue of people that would pile up every week, and one day in a week he'll talk to them. So everybody was coming in the queue. There was an old lady with a little kid. As she came close to Gandhiji, she told Gandhiji that this boy takes a lot of sugar and I have not been able to convince him, you convince him. So even this used to happen. So he didn't lose his patience over it. That, how can you ask? The other attendants were getting angry. Is that something you asked Bapu at this point? He said, no, it's not. So he told her that to come after 1 month. She said, tell him no. I've walked so far, I've come from so far. And this is not I'm not asking rocket science. You please tell him, he will listen to you. He says, no, afterwards. So after 1 month, she again was in the queue. She landed up there. Then he says, here he is. The mother brings the baby in front, the boy in front. He starts saying, sugar is bad for your teeth. Sugar is bad for your tummy. Don't take a lot of sugar. Sugar is not good. And if at all you feel very, very, desire for it, try to control it, etc., etc. 5 minutes lecture. When the lecture was over, the old lady said, this you could have told last time. So the problem is, last time even I used to take a lot of sugar. I've stopped it for a month before telling him. That's a lesson to be taken. So as a doctor, don't give an advice, stop alcohol, stop smoking, you're smoking. That makes no sense. So before you give advice, stop yourself. So when I tell somebody don't take alcohol, I'm very sure that I don't. So I tell him very confidently, otherwise you're cheating. Therefore he starts saying some amount is okay. That's to cover your guilt. If it is bad, it is bad. There's nothing like a moderately bad. Okay, but before that, correct yourself. So when we become judgmental, telling everybody, don't do this, we have to correct ourselves first before we do. Especially as doctors, right? Now what antibiotics you put him on and for how long this drain is going to stay?
Yes, sir. We can remove the drain, sir, today, sir.
What's the problem of this drain? What can it do?
So it is a source of infection first, sir.
What is itself is a source of infection?
It will keep on draining, sir.
Pancreatitis. Now the pancreatic tail is close to the drain. Therefore, if you're smart, you'll put it away. And we prepared a video of some drain in that patient where we had done necrosectomy. I think that video would be soon available to all of us. It's there, no? You saw it. So putting a tube in a tube and then stitching what is a sump drain in that patient of necrotizing pancreatitis where we did necrosectomy, we had put it. Here the drain should be out as soon as possible because the spleen is out. There is no pus there. Don't let it be there. Don't let this cause infection. Okay? Yes.
So, but doesn't the drain also help us find out if the pancreatic injury is there? So won't that reason make us keep the drain for a longer time?
Brilliant. So he's saying, can't we keep the drain for diagnosis? This used to happen. We left the drain so that if there is an anastomotic leak, we will know. We left the drain so that if there is bleeding, we will know. This is not acceptable. Because after 48 hours, the drain gets sealed off automatically by omentum because omentum will go wherever there is a foreign body. So they stop functioning after 48 hours. Now if it is functioning, probably it is irritating and causing more drainage. So it causes more harm than you to diagnose. Will that be the only way to know there is pancreatic leak? Your question is valid, don't be upset. I'm not trying to say that your question is ridiculous. All questions are good. And all questions deserve an answer. Especially in science. Because always is always wrong and never is never right, especially in surgery. So I would not say never put a drain, but I would not put a drain. We used to put a drain to know the diagnosis later on, but no longer. It doesn't help. We'll have features of pancreatitis, no? If there is a pancreatic leak. We'll go for features of pancreatitis. Then imaging can tell you. Ultrasound will tell you if there is collection or not. So we don't really need it now. Anything else?
So can splenic abscess patient can be managed by similar to liver abscess patient? Like in liver abscess we will put pectoral catheter and liver Gleason's capsule is thick and splenic capsules are comparatively thin.
That's a very good point. We did that first time. That's what we did, but it failed. See, it depends actually. The answer is not yes or no. It depends. If there is a minimal amount of collection, that will sort out. If the spleen itself is diseased, it will produce more pus. It did not work in this case, but you can initially try using a pigtail, and especially in an immunocompromised individual, percutaneous drainage is not a bad option. You can even put in a thick drain and you can let it drain. So at least it will bail out, and then you can plan for surgery later. One more cause of splenic abscess is typhoid. Because typhoid leads to splenomegaly, you know? The cause is the same. And the Salmonella typhi can produce, this can produce splenic abscess. I have operated on 2 patients with rupture, where they had an ileal perforation and this, both were. What antibiotics is he getting?
So ceftriaxone and metronidazole, sir.
If the patient is allergic to metronidazole, what would you give?
So metronidazole covers anaerobic organisms. So sir, we can switch him to clindamycin. Sir.
Good.
We are planning for vaccination against capsulated organisms.
Yeah, I forgot to ask that. What is the Aman? What is the problem post clinectomy?
The patient can develop OPSI.
What is OPSI?
It's overwhelming post-clinectomy.
Overwhelming post clinectomy infection, and it's not
Opportunity.
opportunistic. It is overwhelming. Is it common in adults?
Sir, after
It's rare,
trauma-
but in immunocompromised individuals it can happen. So what are the organisms you are protecting against? Streptococcus, pneumoniae and Haemophilus. Malarial prophylaxis used to be given in the past, but our patients have been exposed to malaria before. So we are going to give Pneumovax vaccine. This is the pubic bone. This is the spine. When we talk about a male patient, that's the bladder. That's the prostate. Okay, and this is your rectum. Clear?
Yes.
You have the perineum, the reflection of color. The peritoneum comes down like this. Right. Where is the color? Okay, here. And this is the perineal body. This is the peritoneal reflection. चुप करने के लिए बोल This is the anti-abdominal wall. Please ask him. So basically you are going in this plane. That's why I said wind and water. This is water. This is wind. So this is your plane, no? That's where the growth is. Okay. So that is the APR. So there is a perineal surgeon, there is an abdominal surgeon. Now you have, and of course you have pubo. Levitus, etc. I'm not going there, but the basic part. So when you're doing the surgery, look at it longitudinally. You should not cone down because you'll miss out the TM, the mesorectum. You should go straight. These are called coners. That's a bad thing. You would like to go like a cylinder and get the tissue out. Then you get a margin clearance. Okay?
Yes, sir.
TM. Sharp. Anyway, now how is it doing?
So currently the stoma is functional, sir.
Did we close the skin or we did not?
Skin was open, sir.
Because. Why did we leave the skin open? Right, put it back. You can show it. So why did we leave the skin open?
In class 3 and 4 wounds, there are chances of wound dehiscence in the post-op period.
That's why we leave the skin open. Okay.
We see if patient develop any intra-abdominal sepsis, we know it early, sir.
Abdominal or skin closure leading to anaerobic environment would
It will lead to an anaerobic environment. The fact that you've done a stoma, there was intraperitoneal contamination, so sepsis is anticipated.
Yes, sir.
We leave the skin open so that we don't create an anaerobic environment for the anaerobes to grow. That is why we leave it open. And you can see that it is done well. We can close it later on. So there's no point doing a stoma and closing the skin. That means you're not understood why you did one thing. Let us say negative marking. What do you have negative marking in your exams? -2, no? One for the question that you didn't understand, 2 for the answer that you gave, which again you didn't understand. So there is double negative. Clear?
Yes, sir.
We leave the skin open to avoid anaerobic environment which can precipitate anaerobic infection in the patient. Right?
Yes, sir.
Okay. What is he getting?
So patient is getting ceftriaxone, metronidazole and amikacin, sir.
Patient with alleged history of road traffic accident presented to us with sir features of peritonitis. Patient was sir managed by exploratory laparotomy with sir repair of a lateral duodenal rent via jejunal serosal patch, along with sir retrograde duodenostomy and sir a feeding duodenostomy and nasogastric tube passed during the perforation. With a sum drain. Sir, along with that, the patient has a retroperitoneal hematoma, and sir, there was
an injury here. We had a doubt about pancreas, right?
Yes,
But we left some drain there. That's what the case is about, some drain. This was repaired. The nasogastric tube was guided beyond. Retrograde duodenostomy and a feeding jejunostomy was done, right? And this was taken up for serosal patch. This is the area of serosal. Now the patient has a little peritubular leak, and we put a sump drain where we are looking for amylase. In the drain fluid, and we established that there was mild injury. It was manageable. So we need imaging now. That's what we should do, and we need to explore the wound. Can you just show me the wound? Show it from outside. Now there is a bile leak, and we have found that there's a retrograde tube. What is the finding? Can you just elaborate? It's got a peritubular leak. So that bile is also getting in, so we need to explore it, and maybe we'll take that jejunum further up. We need to hitch it up. That's what we're looking at. Anything else?
the patient on there is this CCT has been done sir, with oral contrast and IV contrast. The report mentions that leak from the D2 segment of the duodenum, sir, with multiple intraperitoneal collections, sir. So
Initially you were mentioning it is jejunal.
So yesterday I told you that it's from D2, sir.
So I'd like to have a look at the CT, and then we'll take a decision on what do we do. But that time we saved his life. Otherwise, you would, if you do more definitive surgery in a patient in a state of shock, you would lose him. So this was kind of a bailing out. Now we'll work towards something that I do very frequently, that is a lateral duodenostomy or pylotic exclusion and gastrojejunostomy. These are the options.
Patient with a case of alleged history of fall from stairs, after which patient suffered trauma. Patient came to us with complaints of perforation peritonitis, symptoms of perforation peritonitis, where he was managed by exploratory laparotomy, which there was ileal perforation 1 feet from the IC junction, and there was a mesenteric tear 1.5 feet from the IC junction, for which division ileostomy was primary bit of the perforation was done, and as a division ileostomy was made.
Now what has he missed out in his presentation?
So there was a alleged history of fall from stairs.
That he has mentioned. You have to mention the score. What is the protocol in a unit? Scoring. What is the significance of scoring, Ayushman?
Yes, sir, significance. We do Apache scoring. According to that, we manage the patient. Sir, if the Apache score is on the grade 3, means more than 16, we 20 sometimes, 20, sir. More than 20, we do only damage control at that time. We do abbreviated surgery, sir, like only ileostomy.
Okay, I'll answer that so that we can summarize it. That's not complete.
If Apache is more than 20, we resuscitate the patient and bring down the Apache to less than 20, and ileostomy diversion is made. And if Apache is less than 10, then we can manage by resection.
So basically, to make it simpler, they're all right, but I'll just put it in perspective. Less than 10, 11 to 20, more than 20. We divide it into group 1, group 2, group 3. If it is group 1, we can do a primary closure, repair everything, resection and stones, whatever. If it is group 2, that is 11 to 20, we have to exteriorize. Stoma, proximal or distal, whatever, or resection and whatever. Group 3 is more than 20, this patient is not very fit for surgery. So we will put in flank drains, resuscitate the patient after the flank drains, because that part we missed out, it's important. With that, the patient becomes a little better, stabilizes, and if we wait for this patient to improve to group 2. Group 2. And group 2 is managed as? So you can take a stoma. So you can do a stoma. So this was group
2, sir.
Since it was group 2, then rest of the story becomes easier for everybody to understand. And this, when anybody is interested, this is my own publication way back in 2002, where we did the triaging of small bowel perforations in managing, Apache to triaging to manage this help-based plan therapy, because that becomes difficult. We wanted a resident-proof method. This is where the trouble is, right?
Yes, sir.
So we can we make an opening in the stomach, which is what you're going to use for gastrojejunostomy as well. And through that opening you put in an inner purse string kind of a vicryl. People used to use earlier Proline. So that becomes PEGJ. These are all diverticalization procedures. These are various diverticalization procedures. The other option is lateral duodenostomy, and same feeding J in retrograde can stay. So it will dry up, and gradually the bile that is coming from here can be fed into feeding J, so the patient doesn't lose much. So that is lateral duodenostomy with FJ and retrograde duodenostomy. Okay? And then you have an option to do, people even put a T tube in the common bile duct to take the bile out. The rest of the process remains the same. There are so many options. So none is perfect, you know that. We tried the fourth one, which is triple tube. The patient is doing well, appetite is improved, but we need to take care of this opening. Another option is, in this opening also we can put in a Foley's for bringing it out. Basically we need to exteriorize, get the bile out of the peritoneal cavity, so that the peritoneal cavity is dry, then it's going to heal. These are various options, so we need to go in for surgery again. I would prefer the PEGJ if the condition is fine, because that takes care of it better. We've seen that it does well. I just told you. अभी एक option बताया था. It must be here only. I'll just show you. No, wait a minute. T-tube.
Yes, sir. Dilated.
But the challenge is T-tube is not dilated, so you need to find the common bile duct, put in a T-tube so that the bile goes out. But does all bile go out is the question. The injury is here.
Yes, sir.
And it leaks like hell, it kills. This becomes a composite leak now, no? Because duodenal contents include pancreatic juice also. It will all digest, so patient will have saponification and everything happening, and it will be a red hot duodenum. So closing it won't work. So in emergency, triple tube is fine, which we did. 1, 2, 3. But later on you can plan now. Okay. Again I am drawing. This is pylorus, no?
Yes, sir.
This is DJ. This is jejunum. So I want to close this pylorus so that the contents don't go down. But at the same time, they have to go somewhere. So I make a gastrojejunostomy. So pyloric exclusion, that means you excluded this. You're doing gastrojejunostomy, but along with that, these tubes can stay so that we keep that, basically the duodenum has to be kept dry. That's the purpose.
Sir,
Is that okay?
in this case, like you are talking about, we use vicryl suture, so we are doing it temporarily.
Yeah,
So it
vicryl
will-
because we want to do it temporarily. Otherwise, if you put, people were using Prolene earlier.
Yes.
This was completely closed. But Prolene had another disadvantage. It will cut through, it may give way, it may produce ulcers there.
Yes.
So a lot of people use vicryl also. We use vicryl. So I'll prefer to use PDS,
Yes.
which is a delayed absorber. Vicryl is virtual monofilament, no?
Yes, sir.
Vicryl will get absorbed in how much time?
21 days.
21 days. Because it's a virtual monofilament. What does that mean? Multiple fibers but covered in a sheet. PDS is a proper monofilament, delayed absorber.
Could we have done this procedure in the first setting and second patient?
That's a very good question. But then you need some expertise, and patient should be fit. So the performance status of the patient and surgeon, both are important. He had massive injury, and you were looking at pancreatic injury also.
So, 27 years lady presented to us with complaints of per rectum bleeding for last 3 months and increasing constipation for last 2 to 3 months, and along with history of anorexia and weight loss. And sir, on examination, the abdomen was distended, and the rest of the abdominal examination was normal. Per rectal examination, there was a growth felt 2 to 3 centimeters proximal to the anal bulge, which was hard in
2
consistency.
to 3 centimeters.
Yes, sir.
Here I see a breast patient.
Yes, sir. Sir, 2 to 3 centimeters distal to proximal to the anal bulge, which is hard in consistency, and sir, it is annular, and sir, finger can be partially inserted beyond the growth, but I can't get above the growth, sir. The swelling.
Just getting mixed up. I don't understand.
So
Can you go beyond it, or you can't go beyond?
I can't go
can't
beyond
go
it.
beyond.
That is the issue. There is not.
I can't go.
And it looks like complete obstruction.
Complete obstruction. Yes, sir.
So there is a complete obstruction. How old is the growth?
At least 2 years.
So it's late. Now, is it fixed to the presacral fascia?
No, sir.
How would you establish if you can't reach there? You can't move it. Huh? You can't make out. Okay. And she's losing blood. She's bleeding. That's why she's got anemia. That itself becomes a reason to operate on this patient early. We have discussed about APR in that case.
Yes, sir.
And we all also discussed that it will be easier in a lady because of the answers given in the previous case. Anything different in this patient that you would observe in contrast to that gentleman there?
young age, sir. Very young age patient.
Young age is good news or bad news?
Bad news, sir.
Why?
More aggressive, sir.
So what all you would look for in the biopsy that you send? What is the histology? You look for adenocarcinoma, it is moderately differentiated, it is, so we'll look for differentiation. That is the grade. What else?
Sir, we can, the pathology report might mention whether it has mucinous cells or not. That may indicate its ability to spread more aggressively than normal histology of a
Okay, fine. What
adenocarcinoma.
else? We look for microsatellite instability,
Yes, sir. Yes, sir.
important point. And
And this is during the colonoscopy, we look for the other synchronous malignancy or
we've done a colonoscopy in this case.
Yes, sir, rectosigmoidoscopy has been done, sir.
polyp
And
polyp to look.
It has been done. You can't do without colonoscopy. So delete that part.
You can also look for mitotic index.
That you would see anyway.
MSI.
So mucinous part is important. You get a signet cell appearance. Signet cell is where mucin pushes the nucleus to the periphery. So more mucin means bad news. They do more aggressively. Microsatellite instability, and she seems to be having symptoms of obstruction and tenesmus both. You need to exclude the sphincteric involvement. And MRI is what is very, very important. She has no lymph nodes in the imaging. That's all you can do. You can't find out otherwise. And it is too close for comfort as far as sphincter is concerned. So what should be our policy?
Neoadjuvant therapy.
Neoadjuvant chemoradiation is an option to downsize, downstage, and this patient being young, we should make an effort to preserve the sphincter.
Sphincter.
But she is having features of obstruction, so what should we do immediately?
Ileostomy, sir. Divergent ileostomy.
You can do a divergent ileostomy, which can be handy later on also, because when we'll do low anterior resection or ultra low anterior resection,
Ileostomy
we'll
already
be
in place.
ileostomy is already there. So patient's acute symptoms will be taken care of. Patient can be put on chemotherapy and radiation, and subsequently can be taken up for sphincter preservation. That chance must be given to the patient rather than an APR, which is an option. You should always have it as a plan B, but you should try and preserve the, if possible, sphincter preservation should be our intent. That's where it is different. But the other difference here is you rightly mentioned young patient, so more aggressive cancer. Two, she is just delivered a baby, I think 2 months back. So she's breastfeeding, which she's not able to do. Anemia is taking its toll, right? So we need to take that into consideration. एकदम ठीक हो जाओगी तुम रो क्यों रही हो? तुम्हें ठीक करने के लिए डिस्कस कर रहे हैं? जब हमें थोड़ा अपने आप को मजबूत करना पड़ता है ना? अब अभी वो लग रहा है ऐसा कि सब कुछ अंधेरा अंधेरा सब जगह है, लेकिन जब वो छटना शुरू होता है तो एक कैंडल जलने से ही पूरा अंधेरा गायब हो जाता है. तो वो कैंडल कौन जलाएगा? सबसे पहले आप. तो घबराओ नहीं, हिम्मत नहीं हारते, ठीक है? तुम एकदम ठीक हो जाओगे, बिल्कुल नॉर्मल, कोई परेशान होने की बिल्कुल जरूरत नहीं, ठीक है? और जो कर रहे हैं वो यही सब सोच करके कर रहे हैं कि हम वो स्टोमा कैसे अवॉइड करें, वरना तो आसान है तरीका, जैसे हमने आपसे डिस्कस किया ना कि हम APR अवॉइड करना चाह रहे हैं. हम चाह रहे हैं कि वो परमानेंट जो रास्ता इधर से बनाने का है वो ना बनाना पड़े. तो उसी के लिए सारी जद्दोजहद हो रही है, ठीक है? तुम तो पढ़े लिखे हो, समझदार हो, जो कीमोथेरेपी और वो देंगे उससे वो कैंसर कंट्रोल होकर के छोटा हो जाएगा, ठीक हो जाएगा, तो उसके बाद स्फिंक्टर को बचा लें और सारी कुछ अब चीज़ें अपनी जगह ठीक हो जाएंगी, ठीक है? और चिंता ना करें, बिल्कुल चिंता ना करें.
Included the MRI and the PET CT, sir, it also showed suspicious infiltration to the presacral fascia, and sir, it also said some metastatic deposits might be present in the pelvic adnexal peritoneal region. So,
And is that a finding?
sir, yes, sir. PET CT said, sir, suspicious
PET CT
peritoneal.
is more suggestive. So if that is the case, she is a candidate for neoadjuvant chemotherapy. There is no confusion. And we'll put her on neoadjuvant chemotherapy, but we need to counsel her that we are not delaying treatment. We are not retreating. We are advancing in another direction. And that direction is towards preserving the sphincter and also taking care of those adnexal deposit which you are mentioning, and the doubtful presacral fascia infiltration, because then on table you can't be taking these decisions. We have passed that stage now where you would take a call on the table. That's not a right way to do it. You should be able to plan your therapy ahead of it. So that's why we are discussing it. So we'll take a call based on the PET CT report. Patient goes in for, it becomes a locally advanced rectal cancer. The standard of care is neoadjuvant chemotherapy and then radiation is required. Ideally chemoradiation followed by sphincter preserving surgery. It may be possible that you may have to resort to APR then also, but this is an option that you must exercise to give patient that chance. Any other point?
Lady with right side carcinoma of the breast, which is triple negative, and post neoadjuvant chemotherapy, stages Y, C, P2, N0, M0. She is also HIV positive, sir, and is planned for modified radical mistake.
Why don't you plan conservation for this?
So,
She is also a responder. So the plan is maybe skin sparing with reconstruction, but the patient has to give a consent. She refused. She just wants the breast to be removed. But patient is important. Mastectomy can be skin sparing. We can reconstruct. That option we should leave to the patient. Patient says not filling. So that's a very important point to learn. On paper, theoretically, she's a complete responder. B cup or A cup, small size breast, we can easily reconstruct. So we'll again talk to her. She's not willing. She wants a modified radical mastectomy. We cannot decide on her behalf. We can only advise her. to counsel the patient that breast conservation surgery is not just equivalent to mastectomy, slightly superior now, according to the latest data. We should offer breast conservation to all patients. Our mastectomy rates are very low now. It used to be very high 15 years ago, 10, 15 years. We hardly do mastectomy now. Most of the time we are able to conserve. And if you are doing a mastectomy also, we are able to reconstruct. With oncoplasty, we are able to do it. So that is why, since we have the expertise and available techniques here, so this we should offer it. We'll talk to her again.
Yes, sir.
She is triple negative.
Yes, yes.
So what neoadjuvant chemotherapy would have been ideal, Aishwan?
Yes, ideal taxane-based chemotherapy, sir, adriamycin, cyclophosphamide, and paclitaxel, sir. We use in this case, sir, in triple negative.
What is the source of paclitaxel? All the masters of it's from the bark of yew tree. What's it?
Taxane is obtained as part of
So taxanes are very effective in rapidly multiplying cells. So that is triple negative, and we would be expecting good response. Why do they respond very well to chemotherapy?
Aggressive tumors, sir.
So
Rapidly grow.
They are undifferentiated, more undifferentiation, sir. There is a more, the chemotherapy will work on the tumor, sir.
Right?
So rapidly dividing cells are the most.
Basically, rapid proliferation
Yes, sir.
is what leads to more action, and chemotherapy acts best on the rapidly multiplying. So this should be. This is why we call it the triple paradox. Triple negative breast cancers do, otherwise they are bad cancers, but they respond very well to chemotherapy. And all that is black is not bad. Triple negative is not always a bad cancer. And this you can only find out when you put the patient on neoadjuvant chemotherapy, and if you get a pathological complete response. The question that you asked in the morning about the other case, why didn't we go for upfront surgery? That was the reason. Because triple negative, neoadjuvant, we find out that the response, if there is PCR, this is going to be one of the better triple negatives. Triple negative otherwise may be bad. So that's the plan, and all of them would require radiation anyway. So now she is a complete responder. We can offer her skin sparing. So that is what we will try to convince her.
Left-sided carcinoma of the breast, managed by modified radical mastectomy of the left side 1 year ago.
Where?
Sorry, sir. She was managed by lumpectomy and axillary dissection level 1 in our unit 1 year ago.
Stop it.
So it's a follow-up case,
Don't record.
follow-up case of metastatic left CF breast, operated on 1st April of 2022, managed by left MRM with level 1 lymph node dissection. She has received 6 cycles of chemo prior to the surgery outside, and she received 7 cycles of chemo in here, sir. And now she has come with local regional recurrence on left side with fungating mass, and she also has a lump on the right side of right breast. Now she's come to us in a state of abdominal distension and shortness of breath, ultrasound revealing gross ascites, for which yesterday paracentesis was done and 2 liters of fluid was drained.
अभी बताना ठीक से. As you open sir, then you start.
ऊपर कर लीजिए.
थोड़ा ऊपर करिए. इसको भी ऊपर कर लीजिए. Give me a pair of gloves.
Of gross ascites, along with the 2 hypertrophic lesions in the liver, sir, indicative of metastatic disease, sir.
It's a metastatic disease anyway. We don't have to. माता जी एक बार देख लें. थोड़ा उधर कर लीजिएगा मुंह. ठीक है? You can actually, you missed out something in the examination. Describe this examination. Aishwan, you should have studied it. You have presented this case. There is definitely distension, but you can see huge liver. लंबा सांस लीजिए माता जी. मार कर उधर भी करके लगा. You can see dilated veins all around. Come feel it. Right. Reach it. Feel it. Put the gloves. That's the liver. थोड़ा निशान लगा रहे हैं, ठीक है ना? कोई दिक्कत तो नहीं. That's the locoregional recurrence, and you can see the. Can you throw some light? खाली खड़ा रहता है कुछ दिमाग में. Suddenly you go number. What are you? हाथ हटा लो. This is a satellite module. थोड़ी रिकॉर्डिंग करना, ठीक है? कोई दिक्कत तो नहीं? Thank you. It's fixed to the chest wall. I won't cause her pain. There is hepatomegaly, confusion. It's a metastatic. If you had looked at the lesion, you can see the scar of mastectomy. There's no question of anything less than that. But now, in a year, she's come back. Even that time, she was a metastatic disease. And our views about doing surgery for metastatic disease are therefore mostly against it, because they come back with vengeance. And it's not a good idea to do it. But why did we do it? Because that time also it was a fungating mass. For a fungating mass, we don't have a choice. Patient had left us with no option. But we could achieve the clearance. Margin was clear. We closed the skin using a LICA, which is just a transposition flap. Finally, patient received radiation. Everything was done. Come back in 1 year. Already a metastatic disease. She has developed ascites now. She has developed lung mets. She has developed lump in the other breast and contralateral axilla also. What should we do now? What palliation? Pain management. First thing. Nutrition. Fluids. Paracentesis whenever it is intractable ascites, respiration should be taken care of. Right? And there comes a point when you should not make treatment worse than the disease. So don't just insist on putting on any aggressive therapy, but can be given oral 5-fluorouracil. What is that? Capecitabine. This is what they have started. We'll discuss the case in the MDT and get a decision. No surgery, natural. Correct? Anything else?
So in case, not in this case, but usually if patient come with loco-regional recurrences, then what should be our plan? If previously MRM was done or previously BCT was done, breast conservation.
No, that is non-metastatic disease.
Yes, that is in
Not this case, no?
Not this case, sir. We are not talking.
Locoregional recurrence, LRR.
Yes.
What is locoregional recurrence? You should define first. Along that is ipsilateral chest wall, ipsilateral axilla, ipsilateral supraclavicular fossa. Can you repeat that?
Yes, sir. Ipsilateral chest wall, ipsilateral axilla, and ipsilateral supraclavicular.
Any recurrence here is called locoregional recurrence. It will be very important. It will be prudent to get a metastatic workup done.
Yes, sir.
It's a good situation to get a PET scan done if possible. And if it is a non-metastatic disease, it's only locoregional recurrence. Look at the reasons for recurrence. What was the last surgery?
Yes.
What is the margin like last time? Naturally, if it was done here, margin was clear.
Yes.
We knew the report. If the patient has shifted from somewhere else, you would like to know the entire status. And then we would like to know the marker status, ERPR, HER2 new, previously. We'll get it done again. So we'll investigate it like a fresh case. Triple assessment, followed by metastatic workup, and based on that, you'll make a decision. If it is still possible to get a R0 margin, we'll resect. Even if it requires reconstruction, we should try and resect. Obviously, if you have done conservation in the past, mastectomy is the answer now. If you have done mastectomy in the past, you have no choice but to remove whatever is there with a clear. These are the options. If she is a hormone positive case, then you have a long term hormone possibility. That's a good one. Usually they do better. It will depend on that.
Yes, sir.
Okay? You also have an option to give radiation upfront if patient is not willing for surgery, but that is not as effective.
Sir.
हाँ. भूख लग रही है?
Yes, sir. WHO ladder.
This will be more or less a state where
In
you
this case, we do
opiates would be required. So we should go for morphine and also the pain clinic. Whatever they advise. In addition to this, she needs nutrition. So let's start with the central line and you can feed her. So she's going to require that. Nutrition, hydration, pain management in the reverse order. Pain, nutrition, hydration. And it's a good idea to do some paracentesis once in 3 or 4 days so that your abdomen is at comfort.
60 years lady came to us in the emergency with complaints of pain abdomen and signs of peritonitis. So intraoperatively there was ileal perforation proximal to a non-passable stricture for which resection of which was 1 feet proximal to the 3.5 feet proximal to the IC junction. Resection of the stricture and the perforation was done. I'm sorry, I forgot to mention the aperture. It was 7, sir. And sir, exteriorization of the resected both division loop ileostomy was fashioned, sir.
Now, but here we deviated from the protocol. Our protocol is group 1, you should do primary closure and anastomosis. So why did we deviate? I'm not saying we were wrong, but why?
So there was a lot of contamination, sir.
Then there's no point having a protocol. It was the bowel itself, it was very dilated. The anastomosis wouldn't have worked. What you are asking in the other case. And in a dilated bowel in acute scenario, it's very, very dilated. So the anastomosis may not work fine. And this 7 is the calculation, you have to go back, and then when recalculated it was 12. So if you don't calculate it correctly, the protocol will go wrong. But why did we remove the stricture, Terry? Why couldn't we just leave it, just do a diversion?
So because pathological segment has to be removed. So
The pathology has to come. So you don't do, what is stricturoplasty, Aishwan? This is your question.
Strictureplasty, in that case, we don't resect the stricture, we longitudinally make an incision and close it transversely.
What is the disadvantage of stricturoplasty?
So,
Diagnosis, we don't know the diagnosis.
And so do you never do? Bolo?
Already we are leaving the pathological.
So leave the pathology behind. That's one answer. So why? Is stricturoplasty totally abandoned, or you do it sometimes?
We do it, sir, when a lot of strictures are there and we resect them all. When there is a risk of short bowel syndrome and there are a lot of strictures.
So you didn't put it you answered it, but for the benefit of everybody, multiple strictures but at a distance from each other. So you're not able to resect a segment.
like Crohn's,
Then you have no choice.
like Crohn's,
Like in Crohn's, you have one stricture, then next here, then next there. So you can't resect the whole segment, no? Or you'll have multiple anastomosis. So that is where sometimes you may have to do stricturoplasty, but by and large, stricturoplasty is a poor surgery. Why do strictures form in tuberculosis?
So there is a lot of fibrosis.
Why there is more fibrosis?
So due to tubercular ulcers form in these, and granulomas are formed, which
Ischemia is the most
The tubercular ulcers are characterized by endarteritis. So they are ischemic. More ischemia means more fibrosis. And more fibrosis means more stricture. You were taught in pathology and anatomy that typhoid ulcers are longitudinal and tubercular ulcers are transverse. That is too small to produce a stricture. So that's one possibility maybe, but primarily it is ischemia. And tubercular ulcers therefore don't bleed. The major cause of enteral bleeding or ileal bleeding is usually typhoid or some other inflammatory bowel disease, but not commonly tuberculosis. Why? Because there is endarteritis in most of them, which leads to lesser blood supply. But where would they bleed? Immunocompromised individual, because there is less fibrosis. The same thing applies to duodenal ulcers. Duodenal ulcers happen in acute perforation happens in acute ulcers or chronic ulcers.
It's in acute, sir.
Not in chronic. So when you hear about this story, patient has been having dyspepsia for last 2 years, so he is perforated. Not common. Because chronic duodenal ulcers would have produced fibrosis. So they would normally produce obstruction, pylotic stenosis kind of a picture, outlet obstruction. Acute ulcers perforate, or immunocompromised individuals, acute can, when a chronic can also perforate because fibrosis doesn't happen as well. So immunity being low. Same principle applies here. Tubercular ulcers rarely bleed. And another reason why when you do colonoscopy, you may miss tubercular ulcers because they are mostly submucosal. When the alligator forceps, you may not get the granuloma. So they are the tubercular lesions. So you miss out. Therefore, lymph nodes are a better place to find the tuberculosis diagnosis than in the primary. What are the components of primary complex?
So draining lymph nodes are along with
The focus with the lymph nodes, with the lymphatics, with the
Three parts, no? Bones focus, lymphangitis, lymphatics, and the lymph node. 1, 2, 3. And Gold's focus would have those tubercles, no? Which is what is characteristic. Now, how is she doing?
So the patient is vitally stable, sir,
And
ambulating.
the other thing which you should all remember in surgery, it's a principle. Whenever in doubt, take it out. Do a stoma when you are having a doubt, but don't have it too often. Because you save the life, but morbidity increases. No? Stoma needs closure later on. The patient doesn't want a stoma. So in all patients, when you're going in for perforation peritonitis surgery or bowel obstruction, take a consent for stoma as a routine so that you're able to take that decision on the patient. Okay?
Yes.